This is Dr. Sargisian, and today we'll talk about alteration of digestive system. And this is an overview of digestive system, and which also includes liver and pancreas. One of the most common disorders an alteration of GI system is gastrointestinal bleeding. So bleeding can be upper and lower. And upper we consider esophagus, stomach, or duodenum. And lower GI bleed is below the ligament of Treitz, or bleeding of jejunum, ileum, colon, or rectum. So that ligament of Treitz is kind of the border, and also the color of the bleed may change. Like the brighter the blood is, the lower it is, and this kind of one of those nursing things from day one you started working as a nurse, or the first month you definitely had someone with GI bleed presenting. And patient, if they have upper GI bleed, they may present with hematemesis, which is bright red blood, vomiting, coughing up blood sometimes can be confused as hematemesis, and coughing up blood is not hematemesis. When you're taking patient's history, please ask to clarify where the blood's coming from, because sometimes patients would see blood, they said, oh yeah, the blood came out of my mouth, but it was not hematemesis, it was hemoptysis. So perfuse bleeding during the vomiting, or blood mixed with vomit, or perfuse blood, it's hematemesis. Also, hematemesis is considered when patient is having coffee ground emesis, somewhat digested blood in the stomach, but patient vomiting that. Also not a good sign. Remember that this is medical emergency, no questions asked. This is one of the things you have to transport patient to ER as fast as you can, and the patient need to have upper endoscopy with cauterization or whatever needs to be done to stop it, because there may be several causes for this, not just ulcers, bleeding. Hematochezia is blood in the stool. So sometimes people would call hematochezia melena, which is not correct. It's a profuse red blood in a stool. Melena is dark, tarry stools, black stools. You don't really have no way to say that melena is blood in the stool, but definitely, or most of the time, melena is blood in the stool, the black tarry appearance. However, let's say with overuse of Pepto-Bismol, patient may present with black stools, tarry stools. So another history taking hint: if patient complains of melena, they say they have black tarry stool, make sure that they weren't taking Pepto-Bismol or any other bismuth preparations which can discolor the stools. Occult bleeding is occult. You don't see it by when you are observing the stools, when you are examining the stools. However, it can be showing up on occult blood testing, and occult bleeding is a concerning sign because this may be representing a bleeding malignancy and representing colon cancer. So that's our upper and lower GI bleeds. Occult bleeding can be slow upper GI bleed. It even can come from dental disorders, or for example, patient had a tooth extraction and then had occult bleeding testing, and it came positive. Probably it's a good idea with that history to wait a couple of more days and redo the occult bleeding testing, hemoccult testing. But even toothy extraction and swallowing some blood may result in occult bleeding or occult hemoccult positive test, which doesn't mean that bleeding comes from colon cancer or an ulcer or something like that. So overall, upper GI and lower GI bleeds should be considered and are medical emergencies because there is a risk of perforation, the risk of losing blood and profuse blood loss anemia. Occult bleeding, on the other hand, it's not medical emergency. However, it may represent a serious condition like cancer and should be addressed fairly quickly and evaluated. In both cases, in lower and upper, endoscopy, lower and upper, is indicated for further evaluation. With occult bleeding, patient needs to proceed with a thorough diagnostic workup that will include CBC and to check for anemias, and also by CBC I mean truly hemoglobin and hematocrit plus the REDS RDW, and check for hypochromic and microcytic anemias, cells, MCV, MCHC, those type of things. But CBC also will be, with differential, may be useful because if there are some type of cancer, to look for unusual white cells. But at the same time, occult bleeding may warrant both upper and lower GI to further evaluate for the source of bleeding. Dysphasia is difficulty swallowing, and there are two types of this: mechanical obstruction and functional obstruction. When we're talking about mechanical obstruction, this is some type of narrowing of esophagus, some type of stricture or a ring, such as like Schatzky ring, a ring of connective tissue, scar tissue that occurred, and usually this is a consequence of gastroesophageal reflux disease. Another more concerning sequela or pathophysiology of dysphagia is having a malignancy or a benign tumor that causes obstruction and difficulty swallowing. So that's the dysphagia. So patient will have complaints such as food getting stuck right here and showing behind the sternum, may complain of chest pains related to food ingestion. Of course, we are very vigilant about chest pains, and you have to, every time is chest pain complaint, you have to distinguish, is this cardiac complaint, is this emergency, or is this something like GI related, definitely. So you have to examine the correlation of food ingestion and chest pain occurrence in this case. So food getting stuck, that will be the concern of patient, and sometimes patient would say, I have to rage, I have to vomit it, and they will say that they are having undigested food coming out. Achalasia is a very concerning disorder, and it's a denervation of the smooth muscle in the esophagus and lower esophageal sphincter. And what happened during the achalasia, the esophagus collapses and turns into very narrow passage or completely closes. So during the achalasia, patient would have build-up of food bolus and eventually would vomit it. Patient will have complaints of inability to swallow, and they will always rage. So again, dysphagia is difficulty swallowing. It's truly not related to pain. And same in achalasia, they won't have the difficulty. I'm sorry, they won't have the complaints of pain, but they will be complaining of dysphagia, complaining of inability to pass the food, and they have to retch and get the food out without digesting. The complaint will be, I see the pieces of undigested food, and I see, it just doesn't go through. And achalasia is fairly emergent condition, not fairly, it's an urgent to emergent condition, because patient does not have ability to have food intake. Sometimes it's so tight, so even fluid intake will be difficult. And patient may experience, if this is untreated, patient may experience severe weight loss, nutritional deficiencies. So this needs to be treated, and one of the treatments is possibility of having Botox injection, and besides the cosmetic gastroesophageal reflux disease, it's also a disorder of motility. However, this is not dysphagia where food bolus cannot go down into stomach. It's opposite. The food bolus is going up, and it's a reflex of chyme from the stomach to the esophagus. Chyme is acidic substance, acidic mix. So esophagus isn't designed to have exposure to the acid. So this causes all type of problems such as esophagitis, or even strictures and rings, like I said, or even can predispose the patient for the esophageal malignancy. And gastroesophageal reflux disease will cause inflammation of the esophagus, and it will be called, of course, esophagitis, and the treatment may be directed to reduce acidity overall, as well as to try to recreate lower esophageal sphincter functioning. So that will be very hiatal hernia. Hiatal hernia is sliding of the part of the stomach into chest cavity, basically through the diaphragm, and in this case it may slide sometime, or it may be paraesophageal, just non-sliding hiatal hernia. But the problem is that lower esophageal sphincter doesn't have the help or diaphragm around it, so it's much looser and isn't able to hold chyme down, and everything comes up. Unfortunately, lots of people have it. From empiric experiences, most people I saw having a EGD, they will have some degree of hiatal hernia. If it's paraesophageal hiatal hernia, it may be different manifestation than sliding hiatal hernia, but in both cases, gastroesophageal reflux disease symptoms can be present. It, again, used to be very common to do Nissen fundoplication to try to deal with this and trying to reduce it, but it's a major surgical intervention, and the patient truly has to be very compliant with their lifestyle, and for instance they cannot overeat or they cannot vomit with Nissen fundoplication. That's why nowadays it's one of the last resort treatments or surgical treatment for gastroesophageal reflux disease in general and hiatal hernia in particular. So you would try medication first before introducing anything else like surgically.